Hey everyone, I'm Quentin Cantu. I'm the founder of InPractice Health. We are a marketplace for real-world data and aesthetics. This is the InPractice Health podcast, where we interview clinicians, entrepreneurs, and others in the fields of novel healthcare domains. Joining me today is my first guest, Dr. Tyler Holmig. Tyler is the Director of Dermatologic Surgery at Ascension Seton here in Austin. Tyler, thank you for being with me here today.
Oh, thanks so much. I'm excited.
Would love for you to kind of introduce yourself, go a bit into your background. Would love for the audience to hear from you.
Cool. So I am a dermatologic surgeon. I did a residency in dermatology at Stanford. I did a fellowship in surgical dermatology in Charleston, South Carolina. After that, I went back to Stanford and joined faculty and was there for about 5 years and directed all of the laser and cosmetic dermatology service line there, as well as doing Mohs surgery, which is a technique to remove skin cancer and then reconstruct the resultant wounds. I was then recruited to UT, and so I direct dermatologic surgery at University of Texas and at Ascension, Texas. And so I'm kind of in those same roles. I live in the world of surgical dermatology, removing cancer and doing reconstruction, and then I do quite a bit of aesthetic dermatology as well.
Awesome. So talk to me a little bit about that, because typically I feel like most clinicians in the field either focus on, more strictly medical and or Mohs surgery rather than straddling both. Is that accurate? And I'm kind of curious how you kind of arrived at doing the best of both worlds.
Totally. I kind of have a unique niche in a rare breadth with my career, but I think it works together really well. So my interest in dermatology was always surgery. I really wanted to remove big cancers, do complicated reconstruction. And so in order to do that, I had to do this certain pathway and go to a certain place to do fellowship. When I came back to Stanford, my focus was that. It was how to, removing large cancers or cancers in critical anatomic sites like the eyelid and the nose and rebuilding those structures. But I had a really great chairman there, and he said, Tyler, with your knowledge of anatomy, we could really use someone doing some aesthetics here, both to treat our patients in the Silicon Valley community and also to train the residents. Would you give it a shot? And at first I was kind of like, I don't know. I feel like so much of aesthetics is marketing and snake oil, but I'll give it a shot. And I started to do a little bit of aesthetics and employ that knowledge of anatomy that I had learned doing surgery. And I really started to fall in love with it, because if you do it what I call the right way, with objective improvement, with hitting targets, the outcomes are just as clear as with, there's a tumor on your cheek. Now it's gone. Now you're repaired. You look great. Well, there's a brown spot you don't love on your cheek. Let's use a certain wavelength of light. Let's hit it. Let's remove it. Now it's gone. So I like that tangible aspect of medicine in general. And I find that there's real overlap with what I do surgically and with a laser or another treatment technology. There's not a lot in medicine that you can actually cure, right? I mean, I don't know if you can cure high blood pressure at all. And it's also invisible. So there's a lot of things that are visible. But with what I do, I get to actually really, cure things, and in a way that's tangible and visible, and gives feedback to me in terms of, well, that went well, I like it, or I don't love how that turned out, I wonder what I could do better next time. And that works with surgery, and that works with aesthetics as well. So that's kind of how I arrived here.
Love it. Yeah, we'll definitely have a lot to talk about with regards to the outcomes and objectivity here in a second. First, I kind of want to go through, for the audience members that aren't as familiar with aesthetics. I mean, for me, the more that I dove into the treatments and aesthetics and the mechanism, I was pretty shocked to learn. I think the biggest example is like a neurotoxin. Botulinum toxin is like one of the deadliest substances known to man, and very common. I think probably the most common aesthetics procedure is to get it administered within an inch away from your brain, right? It's called a neurotoxin. I would love to kind of understand, how did it come to be used in aesthetics? It's my understanding that it actually wasn't originally developed in an aesthetics capacity. Kind of, if you could just walk us through a brief history, I
Yeah,
think it'd be really enlightening.
totally. So one of medicine's greatest examples that the dose makes the poison, right? So this has been known as a poisonous toxin. It's derived from a bacteria, Clostridium botulinum. And we kind of known about it in medicine for centuries, but it wasn't until the late 80s and early 90s when ophthalmologists were using it more precisely and in smaller doses for strabismus, so misalignment of the eyes, or blepharospasm, where people like blink and close their eyes, and administering a little bit to the muscles in those areas would kind of slow them down or line up the eyes better. And there was a husband and wife team where the wife was an ophthalmologist, the husband was a dermatologist, and they noticed in one of their staff members when they injected it kind of right between the eyes, she really liked how it looked. And so suddenly there came a realization that, wait a minute, this can be used medically, but it also can be used in a really nice, elegant way aesthetically. And so harnessing that neurotoxin to slow down muscle contraction can relax those wrinkles of the face that, the face, the upper third of the face in particular, is the only place in the body where muscles attach directly to skin. And so we're just inhibiting muscle movement to keep the muscles from pleating and folding the skin and making wrinkles. So that's kind of how it came about. Then obviously it's kind of gained a life of its own and gone many places since then.
Absolutely. Yeah. Fascinating. How about fillers? Hyaluronic acid probably is one of the most administered treatments in the clinic. Your body already produces this. Kind of what does that look like mechanistically?
Yeah. So hyaluronic acid, HA, it's a natural substance. It's like a critical component of the dermis of the skin. So just below the epidermis is the dermis. It's produced by cells called fibroblasts. And its job is to essentially absorb water. It can absorb 1,000 times its molecular weight in water, but it gets broken down. As it gets made, it also gets broken down by the body by an enzyme called hyaluronidase, and so it just degrades over time. So people have been injecting things into the skin and into the face for a surprisingly long time, and there's been a lot of bad things that have come about because of that. Some of which we still see. There are substances like paraffin that are permanent or silicone that have been injected. And then, trying to get a more natural result, folks started injecting collagen, mainly like bovine, like cow-based collagen. There are all sorts of immune issues with that. But we really couldn't use hyaluronic acid because it gets broken down so quickly. It just didn't last. But over time, biomedical engineers developed techniques to cross-link lab-made HA, and that slows down the time that it's broken down naturally by the body. And so that more lasting effect is kind of what eventually helped us volumize the face in a relatively safe manner with those fillers that are so popular now.
Awesome. And then lastly, we come to light, broadband light, intense pulse light. These are also common treatments. The mechanism there is photothermolysis, which is a concept in physics. You are or have been the director of laser, so you're obviously very familiar here.
Yeah, that's the most elegant thing we have. I mean, that to me is the most critical and beautiful development we've had in aesthetics. So essentially, there are different molecules in the skin that I think of as targets. And those individual molecules can be hit by certain wavelengths of light and selectively excited by certain wavelengths of light. And that can affect biologic change that can be really good. So the three main molecules that we treat are hemoglobin, so things that are red. So a lot of this started with kids with those port wine stains, the facial red birthmarks that can be really devastating. So that's comprised of vessels, and inside vessels are red blood cells. Inside red blood cells is hemoglobin, and you can hit hemoglobin with certain wavelengths of light and selectively excite it or heat it up. That's all we're really doing is heat it up, and that can destroy the vessels around it, but not heat the keratinocytes in the skin. So we can selectively get rid of red birthmarks, for example, or other things that are red, scars, rosacea, There's many things, cherry angiomas, age-related growths on the skin that we can target. Another molecule, another great target or chromophore is melanin. So melanin gives our hair, gives our skin pigment, and sometimes it aggregates in ways we don't like just with sunspots, with photoaging. We can use different wavelengths of light to selectively excite melanin and get rid of it. And then the third molecule is collagen. I mean, wrinkles are all about growing collagen. A lot of wrinkles and fine lines and crepey skin, that whole process is driven by a lack of collagen production. The surrogate for collagen is typically water. So we selectively excite water. And we typically do that to make precise injuries to the skin and induce a wound healing response. And from that wound healing response, collagen grows. So those are the three main applications of light that we use on the skin for aesthetics.
It kind of makes sense. You break down the word photothermolysis into its roots: photo, light;
Yeah,
thermo, heat; lysis, which is death, right? So cell
that's right.
death, presumably. Also, it seems like really cool use cases and applications in tattoo removal, which I would assume is probably a growing use case.
Yes, yeah, totally. Although I see a lot more tattoos going on than off. My gosh, I feel like that's a major cultural phenomenon. But yeah, so most tattoo probably its own chromophore, but pretty closely related to melanin. We do a lot better with dark tattoos than with light. Like I mean, a yellow tattoo, even a red tattoo, is really really tough. But a traditional black tattoo, same thing, heating it with a certain amount, a certain wavelength of light, and also delivering that energy over a certain amount of time. So tattoos are pretty tough to get rid of, and we typically want to hit them with a lot of energy over a very short time. And we do okay. All we're trying to do is heat them up, break them up, and then cells in the skin called macrophages sort of gobble them up and take out the trash. So tattoos take lots of treatments over time, just breaking them up and then absorbing them.
Love it. Awesome. Now I kind of want to move on to some of the clinical severity scales and aesthetics. In wrinkles, you've got the Glogau scale developed by the dermatologist Dr. Richard Glogau. For acne, you've got the IGA scale, which is assessing the severity of acne on an acne patient's anatomy. There's other ones: submental fat rating scale for double chin. I think my question to you as a longtime student practicing clinician is, are these the severity scales that you kind of were brought up into the domain in, or are they taught as kind of like the official clinical severity scales? And lastly, do you use them at all in a day-to-day practice?
Yeah, so we know these scales in dermatology, but they're really not used in clinical practice, in my mind. I mean, they're just not super effective for that, right? Like, it's great to have metrics. We can't improve what we can't measure, but most of these are really designed, to me, for clinical trials. They're just they're tough to apply to actual patient care. For one, sort of the mid range, most patients kind of fall in like let's say aesthetics typically kind of fall in this mid range of scales, like the Glogau scale, and it's hard to move someone from one category really to another, and there's no room to really judge small incremental improvements within that kind of moderate range that most people live in. Most of the time we're treating patients not with a single therapy but multiple therapies, and that's really tough to measure as well. So I think that they're helpful, but they don't integrate very well into a real world clinical practice. They just don't. I mean, I use them if a company says, hey, here's a brand new device, assess it for this single indication. Like, okay, we can measure that. But that's not how the real world works. Someone just comes in and says, I'm looking older. I don't really like what I'm seeing overall. And there's usually 3 or 4 or more things involved there that we need to target to get real improvement. And that the scales don't adapt to that. I mean, I do think the newest one from Galderma is interesting. Like, at least it shifts a little bit toward more of a holistic skin quality, but it still doesn't get us where we need to be.
Interesting. Yeah, the the fact that the scales are currently used in clinical trials, I think to me is also somewhat surprising, given the fact that, to your point, what a lot of this you can't actually measure, and there are way more degrees of change than a particular scale will allow for, right? To your point,
Totally.
potentially someone's not going to go from a GLOGAL 3 to a GLOGAL 2 because that's actually a massive jump, right?
Right.
But just because it's not going from 3 to 2 doesn't mean that there's no actual significant material change on the skin.
Exactly. Exactly. But like the truth is that, we have to, when we're using those metrics, we have to really think about what we're trying to assess, because, and we can talk more about this, for assessing devices, there's really not much of an incentive for device companies to show improvement, right? Like they're just trying to show their device is safe. If we're talking about, whether or not we're getting a drug approved or not and going through an FDA protocol, like that's a little bit of a different matter. So I think that's been part of the problem too, is that we're not really trying to, there hasn't been a lot of incentive or a lot of focus on, you know, really markedly improving, measuring and improving outcomes across aesthetics, which is just what frustrates me to no end as someone who really believes in evidence-based medicine and wants to practice it within the realm of cosmetic dermatology.
Got it. Love it. Let's move on a little bit to things that you're seeing that are new or somewhat novel in your career. You don't need to spend much time at any aesthetics conference to see a whole host of new promising treatments in the pipeline: exosomes, PRP, polynucleotides, regenerative aesthetics. I feel like has become this really increasingly buzzy catchphrase. Which treatments are you excited about? How do you separate the promising from the kitschy?
Yeah, I mean, I think you have to separate excitement from evidence. Um, there's always, I mean, since I have been practicing, there's been what I call like a molecule of the month, like every single month. So it's, we always feel like we're just on the cusp of just figuring it all out, right? And we certainly feel that way. Now we're in the age of AI and there's peptides and we're doing biologically active things, but it's, to me, it's the same old, same old. I mean, for something to really, really stick around, at the end of the day, it has to prove that it works and that it's safe. And I I worry about many of the new treatments now because they act in real, real biological via real biological mechanisms, and yet they are not proven. I mean, look at melanotan, right? Like that's pretty wild. I mean, you take a pill and you become tan. Like, look at me right now. Sign me up. I'm in, right? But when you're activating melanocytes, suddenly you see people covered in moles and atypical moles, and melanomas have been reported in those patients. Like, that's pretty scary stuff, and that's a case where, like, man, we're administering something that actually works. Well, how do you prove a lot of this stuff that is being popularized in the media is even a real product, is even sourced properly? I mean, the regulation, right, is so poor that it's hard to know. Is my PRP the same as the guy down the street? Are we isolating it the same way? Are we spinning it the same way? Are we preserving it the same way? So uh, I think that we're at an interesting juncture, especially with the biologically active um, potential, molecules and mechanisms that are being developed. But man, we need objective evidence that they are safe and effective. And I don't know that the marketing industrial complex is really very interested in that.
Are you seeing a rise in patients that are self-administering peptides?
Yes.
Yes,
I
got it.
mean, yeah, no question. I mean, whether that's, at the tennis center where I play and everyone's like a middle-aged person like me, like me trying to hang in there, and injecting themselves, or even with aesthetics. I mean, no question. And some of those are great, right? Like, the fat loss drugs now are changing the world. I mean, but those have been reasonably well studied before they were put out, and a lot of the other substances have not.
Got it. How much weight do you put behind a clinical trial in this space? We talked briefly a bit earlier. Part of the problem with clinical trials in a domain like aesthetics is because you as a clinician, you tinker, you administer polytherapy or combination therapy rather than monotherapy. Very rarely does a patient come in for a single procedure. But, when a clinical trial comes out, how much weight do you put behind it as a clinician?
Yeah, I mean, some, not a ton. I think clinical trials are good at or focused on regulatory questions, not always clinical questions. And I'm a clinician, right? And so I do want to know that something's safe, and they can definitely prove that. But they're generally done in a vacuum, right? Clinical trials are generally monotherapy, single indication. Does Botox work on the crow's feet? You know what I mean? Like that's it. So it's nice. It's nice to have that information, but it doesn't really make a huge impact on someone's overall aesthetic appearance. And then with devices, that's completely different because there are very few clinical trials, and the ones that we have generally just show that this kind of works like another one that's approved and it didn't hurt anybody, so I think we're good here. We're going to go ahead and roll this thing out, right? So I would like clinical trials to get much better, but they're tough, and it's also tough because these are generally healthy patients, right? So it's not that we're treating someone with, comparing two statins and measuring their improvement in their LDL. I mean, it's a little bit different with aesthetics.
Totally. It's also kind of a tricky situation if you're a medical device manufacturer, because if you're truly creating something novel, then you're not going to go through the 510(k) pathway, and it's going to take you an exponentially or significantly longer time and probably millions or tens of millions more dollars in order to get to market. 510(k) pathway is just basically asking you to prove that it's substantially similar to any other device on the market. So you're going to get to market a lot faster. And, the kind of threshold, the barrier to clear is that it's not going to harm patients. Efficacy, somewhat secondary, but it's kind of a tough situation if you're a medical device manufacturer and you do have something novel on your hands.
Totally. You are not incentivized to come up with something novel. You're just not. I mean, it's 510 is nice because things can get to market quickly. Like that to me is pretty cool. It's a positive in many ways. And then it's almost like a company is hoping that clinicians will figure out, oh, we can kind of use this a little differently, like a little off label, and it does something pretty cool. And then that spreads, right? But something truly novel, man, that takes a lot of work, and that is really, really rare in aesthetics.
Yeah. Moving on, I would love to hear if you're using any AI in day-to-day practice. I think that for most of our listeners, every week there's like a new headline about clinicians and AI and healthcare. Some of it is doom and gloom. Some of it is like we're about to enter a state of deep utopia and the singularity. Kind of where do you fall in that? Do you use AI in day-to-day practice? What does it look like for you?
I do not, which is a little bit embarrassing, but I have kind of a good excuse, and many of us do. You know, so medicine, everything in medicine to me with technology, it always seems so clear for so long that certain technologies, including AI, should be applied to medicine. And we can just see that, right? I mean, you can see that with like chest x-rays. I mean, millions and millions and millions of chest x-rays are done. They are super boring to read. There can be like something catastrophic in a chest x-ray that is subtle. And if I'm a radiologist and I'm looking at those all day, like I'm going to mess up at some point. Like AI should do that. That's not happening still very consistently because medicine is so slow to adopt technologies. There's many reasons for that. One of the reasons, at least in my practice, is that I'm part of a big academic and nonprofit medical institution. And so, even our EMR that we use is for all of the doctors in our entire huge practice across multiple specialties, and it is not good. And we have not been able to incorporate AI even into documentation, which is such a clear use case for me. Another use case is when I do Mohs surgery, I'm analyzing microscopic slides, evaluating whether cancer's absent or present. It's wallpaper matching, right? Like AI should be screening that for me and indicating, hey, doc, like wake up, look at this section of the slide and maybe there's a tumor here. That still hasn't happened. But I don't know. It's kind of like how what Hemingway said about bankruptcy, right? It's gradual, then it's all of a sudden. Like that's what's going to happen. I think it's inevitable, and I think some change is tough, but I think largely this is going to be good. I do have buddies in private practice in more like small groups who are using AI for all of their documentation at this point. So that's, and they say like it's a total game changer, which, and that would make my life a whole lot better. That's a real pain point for me.
Got it. Love it. And how do you see the field changing in the next 5 to 10 years? Do gradually, then suddenly you think that like all of a sudden everyone's going to realize the incredible use cases and applications and benefit for everyone in the chain of incorporating AI into things like medical imaging, things like that? Kind of where do you see it in the next decade?
Yeah, I mean, I think medical imaging, I think pathology are low hanging fruit. I think you know allowing improved assessment of changes clinically, and that I mean, not taking a step back from dermatology. I mean, think about what we can do with like wearable technologies now, monitoring heart rhythm, monitoring blood pressure, all sorts of wellness metrics. Like we're becoming flooded with data, and that data is not just when you're in the doctor's office. It's 24 hours a day in many cases, and that data should be analyzed and evaluated. And I think with that, with utilizing AI to do that, it's going to change medicine and healthcare entirely. I mean, I just think it's inevitable. I look at our practice, and a patient comes in and says, she or he's looking older, and there's always this gestalt, like, oh yeah, like, you know, I don't really put it that way when I'm talking to a patient, like, oh, you do look, you're looking really old, but it's more like, oh yeah, I see that, and what I think I see are some changes in your volume and in your texture and in your tone. And here's three things that we can do simultaneously to hit those targets and improve those. And let's look at your photos from last time. Well, now I'm looking at a 2D image with variable lighting, with kind of funky angles that don't perfectly line up, and that's not very helpful. But I think with technology and with AI, that can totally be changed. I think we will ultimately be able to truly measure, truly evaluate and measure what goes into the aging face, what has really changed, and what's changing with dynamic movement, what's changing with your real life and in different, you know, lighting and different scenarios, different um, ambient, humidity and all the things that are real world that aren't just a snapshot with flash or oh shoot, we forgot the flash in clinic. I think that we'll ultimately be able to objectively analyze those changes, and I think that'll guide better treatments. But I don't know. I think we're battling evolution of technology, and I think we're going to battle a lot of the bureaucracy that's entrenched in healthcare to get there, and that's going to take time.
Yeah, I would definitely agree. Besides, besides some of the things that we've talked about on this episode, kind of what are your other big pain points as a physician in this space?
Okay, let's think. So with with my day to day, documentation is an absolute killer. Patient scheduling is really tough, including triage. Like with the skin cancer work that I do, say we're doing eight surgeries a day. We have never been able to successfully make the perfect day because it's a little bit of a box of chocolates. Like some folks come in with a basal cell skin cancer on the nose, and that thing is the size of a pencil eraser. And then that same patient on the schedule that says basal cell on the nose, it's that big, right? And so the whole day goes crazy because suddenly you're taking off someone's nose and fixing it. Like, I think we could get better at triage and scheduling over time. Um, I think that another pain point with aesthetics is is that it's largely unregulated. That's kind of a state by state thing, but let's say in Texas, anyone can kind of do anything in healthcare. So I will do some consulting work for Texas Medical Board, and see the craziest things. I mean, see folks who have not even done a medical assistant training program who are injecting a neurotoxin inches from the brain, injecting a filler that can migrate behind the eye and cause blindness, which I've seen. Um, I think that social media and popular media really pushes beauty and beauty treatments as a commodity that can be administered by folks who don't really have a deep knowledge of the skin and of anatomy. And I think that can be really dangerous. And I think it also causes the public to lose trust in their healthcare provider in general. That's sort of the existential stuff, I guess. The documentation is actually what's killing me, but the existential stuff I think about is more that kind of latter category.
Yeah, ideally, you wouldn't have to review these cases that quote unquote escalate from a purely aesthetic derm to a much more experienced aesthetic plus medical derm, such as yourself, right? Um, I feel like that would be the ideal world. The ideal world would be one in which there's way more evidence in aesthetic medicine. We kind of really double click on some of these scales. We're able to analyze anatomically the degree to which things reduced in the crow's feet, to your example. We're able to really understand what is the optimal protocol for a particular patient cohort. Different people have different melanin responses, to your earlier point, to and things like broadband light. So that's the ideal world. Obviously, a little bit difficult now, given the lack of regulatory framework around some of these domains.
Totally, totally. And patients are on Instagram and on TikTok, and there's folks who advertise themselves as experts who are not experts, who are just not. They're just trying to build a business and aren't really focused on taking care of patients. And I think that's the big problem in aesthetics, is that the focus on actual improvement, actual safety for real patients is often lost.
Definitely lost a little bit. It does seem like everyone's trying to optimize for getting more patients in the door rather than focused on patient outcomes, efficacy, safety,
Totally,
etc. Awesome.
totally.
This was amazing. Thank you for your time. Where can people find you? Where can the audience find you if they're looking for a Mohs surgeon, cosmetic dermatologist, or just to see your content?
Oh, thank you. It's a pleasure. You can find me in downtown Austin. You can look me up. Just Tyler Holmig. I'm on faculty at Dell and at Ascension. So I think there are websites. We have satellites up in Georgetown, down in Buda, but I'm mainly downtown in our laser center. But this was fun. Thanks again for having me.
Yeah, awesome. Thank you so much, Tyler.
Yep, pleasure.